morning we get the pleasure of having Dr. Welt talk to us about one of the hot button topics in medicine across the country, which would be use of marijuana and cannabinoids and how it affects pregnancy. Dr. Welt has been a faculty member here since 88?
81 the first time,
81.
and then 2009 the
come
second
and
time.
gone as he's progressed through his career, and he has been the mainstay of the maternal fetal division for the last, 8 years?
7, yeah.
7 to 8 years. So everybody, please give him your attention. Thank you.
Thank you very much. So I come in and I work my 12-hour day, and I go home and I read for about 3 or 4 hours, and then I like to relax by reading Smithsonian Magazine or National Geographic. And so one day I come home and National Geographic has the following title. And so now I'm stuck having to read about marijuana if I'm going to read my National Geographic. This, by the way, is June of 2015. And so I start reading, and the first thing I learn from the National Geographic and from everything else is that there's a gigantic amount of information out there, most of it completely unsubstantiated. Most of it is totally opinion, and I'm going to show you some examples of how confusing it can all get. And it keeps changing on a regular basis. So today, you'll be pleased to know that on the recommendation of the Food and Drug Administration, DEA is reconsidering its schedule for marijuana. Currently, marijuana is Schedule 1, which makes it the same as heroin and LSD, whereas Schedule 2 is oxycodone, hydromorphone, Subutex, and all that other stuff. And if they change it, marijuana may be a Schedule 2, 3, or 4 drug before the end of the year. I have nothing to disclose. I wish I had some marijuana stock, but I don't. And so here is the story, basically. Marijuana is used medically as cannabis, both in the form of THC and in the cannabinoid oils. It's been used for treatment of glaucoma, multiple sclerosis, HIV, AIDS, cancer, what does this say over here? Recreational use, the respiratory system, for travel, for heart, and for other purposes, all of which are proposals or statements or recommendations which do not have your scientific value. So when you tell me, oh, I want all of this to be medically certified, I want all of this to have some kind of study behind it, every claim for marijuana has no substantiation behind it. This is what's being used. This is the the recreational use here, and the medical use down here. So, what did the National Geographic say? Well, hemp is a tough fiber that's long been used for rope, paper, and fabric. It's also rich in compounds with a medical promise. Charred seeds have been found in Siberia dating from 3000 BC, so it's been around a very long time. And the Chinese were using cannabis as a medicinal for 1,000 years. It's also very American. George Washington grew hemp at Mount Vernon. In fact, we grew hemp for a long time in this country until the beginning of the 20th century. Cannabis in the U.S. was legal until the 1930s and was commonly found in tinctures and extracts. And for 70 years, the plant has now gone into hiding because it is named as a gateway drug. In 1970, the federal government classified it as Schedule 1, a dangerous substance with no valid medical purpose and high potential for abuse. And as I said, probably this year that schedule will change and they will no longer be a Schedule 1 drug. In 23 states and the District of Columbia, cannabis is legal for some medicinal uses. Other companies have legalized it or decriminalized it. And in fact, you can buy it in the Netherlands Army. So while you're in the Army in the Netherlands, you're allowed to smoke marijuana anytime you want. So what did the National Geographic say? Well, temporary effects of smoking may be laughing sickness, intense shoegazing, amnesia, and a ravenous yearning for snacks. That sounds like a Friday morning grand rounds with the residents, okay? There has never been a death attributed to marijuana use. For many, cannabis has become a tonic to dull the pain, aid sleep, stimulate appetite, buffer life's thumps and shocks. And it can be useful as an analgesic, antiemetic, bronchodilators, and anti-inflammatory, and may be used to treat hiccups. It seems a little bit extensive to use it for treating hiccups, but the problem is that when they say can be useful, has been used as, there's a placebo effect. And so we don't know if these drugs, because when you use cannabis, you're using a combination of the drugs, whether they actually have any medicinal effects whatsoever. So what's the history? In 1963, an Israeli organic chemist using Lebanese hashish, okay? I called Ryan to ask him about this. He says it's the best. Lebanese hashish isolated and synthesized a number of compounds. By the way, marijuana generally refers to the leaf and the bud. Hashish refers to a concentration of the resin in the stem and leaves. Okay? So when you're on the street in Lebanon and the guy's smoking his little hookah, he's got a concentrated resin that smells up the whole street. And apparently they think it's very good for arthritis. So little old men are sitting squat on the street smoking this stuff and talking and playing their games. Upon injection into the rhesus monkey, it had only one effect. It calmed a normally aggressive animal. So again, the students have probably heard this, but the rhesus macaca, as mean as it can be, the rhesus fascicularis is the one that we use for all of our studies on placenta because it's a lot calmer. Apparently, when you inject this stuff into the rhesus macaca, it gets as gentle and unaggressive as the fascicularis. So it has that effect. The active compounds are tetrahydrocannabinol and cannabidiol. So an Israeli program now uses marijuana to treat glaucoma, Crohn's disease, inflammation, appetite loss, Tourette syndrome, and asthma, but it's a research program. They are not telling you that this works. High THC strains of marijuana can change the way a developing brain grows. Cannabis can provoke serious and debilitating anxiety attacks, and cannabis may trigger the onset of schizophrenia among those with a genetic predisposition. The chemical made by the human body that binds to the same receptor that THC binds to is called anandamide, or translated supreme joy. Several endocannabinoids and their receptors exist. The runner's high, important roles in memory balance, movement, immune health, and neuroprotectors. So instead of running 5 miles and getting a high, you might be able to take some cannabinoids and get the same high as the runners do. Concept of the entourage effect. Does everyone know what the entourage effect is? Essentially, you get something started and then others join in. And so if you've got an effect on one organ, other organ systems will join in on the same kind of effect from similar receptor sites. There are now more than 480 different compounds identified in the cannabis plant. One strain of hemp has been grown specifically for medical purposes. Cannabidiol and other compounds for use in multiple sclerosis, psoriasis, PTSD, dementia, schizophrenia, osteoporosis, and ALS. And again, the studies are being done. There are proponents for these, but there's no really good hard data to support it. Marijuana itself contains cannabinoids, flavonoids, and terpenes, and low THC, high CBD marijuana strain has been created, which is high in cannabidiol. It's called Charlotte's Web. And the cannabidiol is the oil that some people have been using for children with refractive seizure disorder. So you've probably heard the story of the mothers who are taking their children to Colorado so they can get this oil because the children are seizing all the time. It's not totally clear whether it's this particular Charlotte's Web that's doing it and the type of cannabidiol that exists. So what is Cannabis sativa? It's marijuana. Its self-reported use during pregnancy ranges 2 to 5%, 15 to 28% among young, urban, socioeconomically disadvantaged women, that's not pregnant. 48 to 60% of marijuana users continue use during pregnancy, with many women believing that it is relatively safe to use, less expensive, and less dangerous than tobacco. So some of our patients that we meet will just say, oh, well, I kept smoking into the pregnancy, but now I've stopped, or I switched from tobacco to marijuana because marijuana is so much safer. The medicinal and psychoactive properties come from the cannabinoids, and these are absorbed from the lung when smoked or from the GI tract when ingested. Tetrahydrocannabinol, THC, is a small and highly lipophilic molecule which is distributed rapidly to the brain and fat. So it goes to the brain, but it also will store in your fat for available use. And what you'll see is the chronic user will have difficulty getting rid of some of that cannabinoid. It'll stick around for 2-3 weeks. THC is metabolized by the liver. The half-life of THC varies from 20 to 36 hours, and in occasional heavy users, 4 to 5 days, because again, it's stored in the fat. In heavy users, it may require 30 days for complete excretion, and in animal studies, THC crosses the placenta to levels 10% of the mother after an acute exposure. So is the baby getting it? Absolutely. Prescribed cannabinoids include dronabinol capsules, nabilone capsules, and oromuscular spray nabiximols. A literature study has shown that nausea and vomiting due to chemotherapy, low-grade evidence exists that the marijuana and marijuana products are as good as the placebo. Limited human data suggests that THC also appears in breast milk. It's difficult to assess the effects on pregnancy of THC because people who are using marijuana are concurrently using tobacco, alcohol, illicit drugs, and the marijuana contaminants that occur. And adverse socioeconomic conditions such as poverty, malnutrition, and less likely to have a folate supplement also confuse the data, so you don't know whether this is a marijuana effect or some other effect. Also, these patients seem to have more intimate partner violence and low household income. So what are some of the claims? These are claims. Oh, isn't that pretty? That came up. These are some of the claims. These are the preparations of marijuana. So THC, THCA, V, CBN, CBD. All of these are various different preparations. You can go into your shop in Denver and ask for this by name, and they will find you the appropriate marijuana to give you for these various different effects. So this one, these, the green ones, affect pain relief. Some reduce inflammation, suppress appetite, stimulate appetite. That's kind of cool. It does both things. Reduces nausea and vomiting, reduces contractions of the small intestine, relieves anxiety, tranquilizes, reduces seizures, suppresses muscle spasm, aids in sleep, reduces efficacy of the immune system, reduces blood sugar levels, prevents nervous system degeneration, treats psoriasis, reduces the risk of arterial blockage, kills or slows bacterial growth, treats fungus infection, inhibits cell growth in tumors and cancers, and promotes bone growth. All of these claims are made. You can find this in your local marijuana distributor in Washington or in Colorado. There's really no good scientific information. This is the number of deaths per annum for various different agents. As you know, we're having a terrible problem with opioids, opioid overdoses and opioid deaths. Okay? Marijuana, its proponents tell you, is so safe over here. It is more safe than anesthetics and therapeutic gases, autonomic nervous system drugs, barbiturates, respiratory drugs, acetaminophen. Look at it. Cannabis is safer. So why take acetaminophen? Take your cannabis. It's much safer in terms of death. So what's it used for? Appetite stimulation in HIV/AIDS, low-grade evidence. It didn't work in this study. Chronic pain, it was better than placebo. Spasticity due to multiple sclerosis, insufficient evidence statistically. Depression, very low quality evidence, no difference from placebo. Anxiety disorders, low quality evidence, some benefit, but studies were very limited to anxiety alone. Sleep disorders, low quality evidence, but again, better than placebo. Psychosis, no difference from placebo. Intraocular pressure and glaucoma, no difference from placebo. Tourette syndrome, low quality evidence. THC capsules are beneficial. So if you take THC capsules, you may not curse at people or say bad words quite as often as you otherwise would, depending, of course, where you work. 505 full reports have assessed. They've whittled them down to a total of 79 randomized controlled trials, and among those randomized controlled trials, very little evidence that cannabis or any of the materials that come from it are of value. In all the studies, adverse events were greatest for the cannabinoids in each group, so they're worse than the placebos. The greatest risk of adverse effects serious adverse effects, comes with withdrawal from study because of adverse effects in the number that occurred in the cannabis arm. And what are those effects? Asthenia, balance problems, confusion, dizziness, disorientation, diarrhea, euphoria, drowsiness, dry mouth, fatigue, hallucinations, nausea, somnolence, and vomiting. The unofficial legal reports from Colorado now indicate that they're having many more traffic accidents as a result of cannabis than they ever had as a result of alcohol. So, this is what the people who sell marijuana to you would like for you to see. The brain, addiction and withdrawal. It's good for that. It causes lack of motivation, personality and mood changes, reduced ability to learn and remember. It increases the risk of cancer. It increases the risk of chronic obstructive pulmonary disease. It increases the risk of lung infections. Reproductive system, it reduces testosterone and male sex drive. That's a really good reason for not taking it ever. It increases the risk of testicular cancer. It is irregular menstrual cycles and birth defects in women. It causes bone marrow damage. Sleepy, bloodshot eyes, dry and burning mouth, irritates lining of the esophagus, increases chance of cancer in the esophagus and larynx, coughing and burning, increases blood pressure, increases heart attack and stroke, weakness is increased, immune system's ability to protect the body against infection is reduced, and it increases blood pressure leading to higher risk of strokes. So, there's an article that came out in December of 2015. I was remiss in not reading it any earlier than last week, but this is the testing that they were able to use. They said, in maternal urine, the duration of the positive result is 2 to 3 days in occasional users, several weeks in chronic users. Chronicity of use determines the duration of the positive result. In maternal serum, 2 to 3 days in occasional users, several weeks in chronic users. So when you're asking yourself, what does this result mean, or a patient asks you, how long will my test be positive, these are the summation results from this paper by Metz. And apparently, they've got a lot of experience. They're out of Colorado. In maternal hair, several weeks positive, less accurate for marijuana than other drugs. In meconium, positive results indicate second and third trimester exposures. And neonatal hair, positive result indicates third trimester exposure. So I put this up because I wanted you to get some sense of how frustrated I have been trying to research this. There are about 10 tables in this paper, and these are the last 2 columns out of 6 or 8 columns in each one of them. And what it says to you is these are the findings, adjusted ORs or regression coefficients with a 95% CI, no association with SGA, isolated higher birth rate in heavy third trimester users compared with non-users, increase in birth weight in marijuana users compared with non-users. Women who use marijuana were intentionally oversampled. Every single one of the studies they reviewed has some major problem with how the study was done. And each of these studies has these results and these problems. Regular use in white women associated with low birth weight. It's self-reported data collected early in pregnancy with no later pregnancy data. So every single one of these studies has got a problem. No association with low birth weight. So good, marijuana, great. Study was designed to assess cocaine exposure, not marijuana exposure. So, I mean, how do you use this data? It's so frustrating. and column after column, no association with small for gestational age baby. Oh, there's recall bias, low prevalence of use concern for ascertainment bias for marijuana exposure. Paper after paper after paper makes these claims, and yet they're not substantiated in any real way. Just wanted to give you a sample of those. Their recommendations, based on their complete review, this is again the Colorado People Mets, screen all women verbally for marijuana use at intake of obstetrical care and consider a rescreen later in pregnancy. Consider urine toxicology screening in high-risk patients. Recommend avoiding marijuana in pregnancy because marijuana does cross the placenta. Counsel women regarding uncertainty of effects on perinatal outcomes and possible increased risk of stillbirth. Possible increased risk of preterm birth, but the data is very mixed. Counsel women regarding uncertainty of effects on the offspring and possible adverse effects on neurodevelopment. Possible increased risk of fetal growth restriction, again, mixed data, and no established association with specific congenital abnormalities. Women should be referred who use marijuana and desire cessation to appropriate resources. Local substance abuse or substance use programs do not otherwise modify clinical care. Growth ultrasounds are not indicated outside study protocols for marijuana alone. Screening for preterm birth with cervical length is not specifically indicated. Antenatal surveillance, that is NSTs and biophysical profiles, are not specifically indicated unless you have something else like growth restriction or some other problem. Recommend avoiding marijuana while lactating. Marijuana is passed to the neonate in the breast milk. Possible adverse effects on early neurodevelopment, and provide counseling, but do not withdraw lactation support. So these are the opinions based on these terrible data from the group at Denver. Now, another article comes from JAMA in which cannabinoids are used for medical use. They can be administered orally, sublingually, or topically. They can be smoked, inhaled, mixed with food, or made into tea. They can be in herbal form, extracted naturally from the plant, gained by isomerization of the cannabidiol, or manufactured synthetically. Manufactured synthetically has become very, very interesting because it has become bath salts and types of bath salts, and these have become extremely dangerous and lethal. Adulamic acid, CT3, is 40 milligram capsules. CBD is 200 to 800 milligram capsules. This is usually for use for psychosis or anxiety. 20 to 40 milligram capsules, an oral mucal spray, can be used for glaucoma. Cannabis, liquid vapor, 4 puffs for pain. Smoked cigarettes, 3 per day for HIV. And dronabinol synthetic can be used for nausea, vomiting, pain, spasticity. These are all of the ones that are currently being used where marijuana therapy or cannabinoid therapy is legal. Another synthetic used for spasticity and pain. Naboximoy liquid is used for spasticity, pain, nausea, vomiting. And basically what these are is a group of scientists have gotten together, gotten a strain of marijuana and reduced it to its liquid form or to some other form and capsuled it so that you can have specific dosing so you can now write it as a prescription. The data supporting their use for these various different physical attributes or problems is not clear at all. And that's what's out in the lay literature. So what does Medscape say? Medscape says there are 2 synthetic THC cannabinoids, dronabinol, which is a Schedule 3, and nabilone, which is a Schedule 2. So as opposed to marijuana itself, which is Schedule 1, these are Schedule 3 and Schedule 2 drugs. And the FDA has approved it to treat nausea related to chemotherapy. Dronabinol is also FDA approved to manage loss of appetite in patients with HIV, AIDS, and however, high concentrations of THC will increase the risk of its adverse effects, and the literature indicates that very few patients can tolerate pure THC, thereby limiting the potential use of these drugs. An investigational synthetic has been granted fast-track orphan drug designation, but is not yet FDA approved, for 2 severe childhood forms of epilepsy, as well as a reviewed orphan drug designation for the treatment of tuberous sclerosis. Okay? So these are the ones that the ladies are taking their kids out to Colorado so they can get these drugs. They're still not approved. They're still on protocol. But people are doing this, and they're making claims that may or may not be substantiable. Another investigational drug is administered as an oral mucal spray and is in trials for managing pain in advanced cancer and spasticity and multiple sclerosis. Anybody see treatment of pregnant problems here? I don't. But it's important to follow up on THC CBD users because there is diversion and inappropriate use of these agents. Surprise, surprise. The risk of marijuana use is particular in vulnerable populations. Methods of administration doesn't mean that they're going to use it that way. Periodic evaluation of therapeutic efficacy and appropriateness, so you're giving this drug, maybe over a period of time it works well, it doesn't work well, you have to reduce the dose, increase the dose. Same sort of things that you would do with any of the dangerous drugs we give people by prescription. You want to do the same thing with these drugs as well. Check them out. Make sure they're doing what they're supposed to do and the dosing is correct. Not operating machine or vehicle during cannabis use. Okay? Told you already, more traffic accidents in Colorado than with alcohol. There are other studies showing that you significantly reduce a person's ability to use heavy machinery or cars. The interesting thing is that once they've injured themselves with the heavy machinery and you go out to help them, they don't really care as much as if they hadn't been using the marijuana. Withdrawal cessation strategies such as tapering and slowing down. Neurologic recommendations. So now there is some strong evidence for pure CBD pills and moderate evidence for THC pills in providing short-term relief of spasticity symptoms. Moderate evidence also exists that it may be helpful in cramp-like pain or painful spasms. And regarding other MS systems, strong evidence exists that some of the oral pains can be used for the paresthesia sensation of burning, painful burning, excluding neuropathic pain, and moderate evidence supporting nabiximols for reducing urinary frequency. When the authors say moderate evidence, there is no national standard for that. It's their interpretation of what kind of evidence they have. So you can't find a statistical number, you can't find an analysis by this method that I don't really understand because I have to ask a statistician every time I want to do one of these things. But you will not find that data in these studies. You will find an opinion that there is moderate evidence, or there is good evidence, or there is no evidence. With Parkinson's disease, the pills probably do not alleviate levodopa-induced dyskinesias. In epilepsy, there's insufficient evidence to show the efficacy of any form of cannabis in reducing the frequency of epileptic seizures, and not enough evidence exists to show whether synthetic THC will alleviate the HD motor symptoms. There is an adverse effect. Overall, the risk of serious psychopathology occurs in about 1%. Pain information. There is increasing evidence regarding the efficacy of medical marijuana in managing chronic neuropathic pain and chronic non-malignant neuropathic pain. However, further investigation is needed, particularly regarding the long-term efficacy, safety, and best routes of administration. Canadian Pain Society Consensus Statement on Chronic Neuropathic Pain recommends cannabinoids as a third-line therapy. Okay? Third-line therapy. I have now been dealing with diabetic neuropathies for a very long time. And the way diabetic neuropathies is treated is by shooting them with a shotgun full of everything. All of it works. None of it works really well. And we just keep rotating our drugs from one visit to the next visit to the next visit. And there doesn't seem to be anything that really, really works very well. Right now, Lyrica and gabapentin are the drugs of choice for starting because it appears that they don't have as many side effects as the narcotics do. But again, marijuana is not the answer either. Findings from retrospective studies that analyzed data of 121 patients diagnosed with migraine showed symptomatic improvement in 39.7%, including 19.8% who reported prevention and reduced frequency of migraine, and 11.6% who reported that the migraine was aborted. However, 11.6% reported negative effects such as somnolence, and edible marijuana was associated with more negative effects compared with other forms. Cancer and chemotherapy. Some laboratory evidence suggests that cannabinoids may have an anti-tumor effect in colon cancer, breast cancer, and glioblastoma. However, the data are not consistent. With regard to chemotherapy-related nausea and vomiting, the antiemetic effects of synthetic Thc cannabinoids are well established. The National Comprehensive Cancer Network incorporates dronabinol and nabilone into its guidelines for supportive care. But these are very specific types of nausea related to these drugs. And you can't just say, oh, well, Zofran worked really well for them, so let's use it in pregnancy. You can't say, oh, well, the marijuana drugs used worked really well for them, let's use it in pregnancy. That application doesn't apply. Gastrointestinal use. There is anecdotal evidence to suggest that cannabinoids may modulate the ECS and thereby affect gastric emptying and colonic motility. Certain strains have a higher CBD amount than others, and although cannabinoids may have the potential to target treatment of gut disorders, more human trials are needed to investigate these effects. Glaucoma. In 2014, the American Academy of Ophthalmology reiterated that it does not recommend the use of medical marijuana or other cannabis products to treat glaucoma, particularly when standard therapies are available and effective. Okay, so if you go on any of the hotlines or websites for the purveyors of marijuana, they'll say, oh, it's great for glaucoma, but they ignore this 2014 report basically saying don't use it, it's not, we got other stuff that's better. Currently, there is no scientific evidence for its long-term efficacy in managing glaucoma. Safety. Regular cannabis use is associated with gray matter volume reduction in the medial temporal cortex, temporal pole, parahippocampal gyrus, insula, and orbitofrontal cortex. Diminution in the gray matter is particularly problematic among young adults, high users of marijuana. For attention deficit disorder and a group that is prone to self-medicating. Cardiac system. Cardiovascular effects include an increased rate of acute myocardial infarction and cardiovascular mortality, as well as an association with higher rates of acute ischemic stroke. Cannabis use in pregnancy does not appear to be linked with higher rates of birth defects. However, it is associated with disruptions in the neonatal brain functional connectivity. In utero, cannabis exposure also causes profound T-cell dysfunction and a greatly reduced immune response to viral antigens. Other safety information. Neuropsychiatric effects of cannabis use will include its being uniquely predictive of the development of bipolar disorder, panic disorder, agoraphobia, social phobia, as well as declines in mental but not physical health. Sounds like every patient I saw yesterday. Continued cannabis use at 1 year in bipolar 1 patients appears to elevate mood and lower global functioning. The data regarding cannabis use and increased anxiety appears to be mixed. However, there's good evidence for associations between its use and increased risks of depression in adolescents, young adults, late middle-aged, older adults, as well as suicidality, that's a new word for me, in late middle-aged or older adults. Stuff's not good for you. Evidence also exists for early onset psychosis in adolescents who initiated cannabis use before age 18 years. In addition, high-potency cannabis users have almost a 3-fold risk of induction of psychosis compared to those who never use cannabis. Note that chronic cannabis users with subclinical depression appear to have worse outcomes than first episode psychosis. I thought this was hilarious. Okay, ACOG recommendations from, I can't remember if it's one of the standard publications or whether it's from a paper. It may be an Acod Technical Bulletin from 2015. Before pregnancy and in early pregnancy, all women should be asked about their use of tobacco, alcohol, other drugs, including marijuana, and other medications used for non-medical reasons. Women reporting marijuana use should be counseled about concerns regarding potential adverse health consequences of continued use during pregnancy. Women who are pregnant or contemplating pregnancy should be encouraged to discontinue marijuana use, and pregnant women or women contemplating pregnancy should be encouraged to discontinue use of marijuana for medicinal purposes in favor of an alternative therapy for which there are better pregnancy-specific safety data. There's insufficient data to evaluate the effects of marijuana use on infants during lactation and breastfeeding, and in the absence of such data, marijuana use should be discouraged. Central nervous system effects of cannabinoids via the cannabinoid receptor type 1 human fetuses demonstrate the receptor by 14 weeks gestation. So the receptor that the cannabinoids go to is present in the fetus from very early on, and animal studies demonstrate cannabinoids affect the neurotransmitter systems, neuronal proliferation, migration, differentiation, and survival, although no gross fetal abnormalities anatomically are noted. Animal studies indicate impaired cognition and increased sensitivity to drugs of abuse. Children who are exposed to marijuana in utero had lower test scores on visual problem solving, visual motor coordination, visual analysis than children who were not exposed. Data on school performance has had mixed results with more notable effects in lower socioeconomic groups of patients. Studies on structural anatomical defects have also had mixed results. Studies looking at perinatal and infant mortality do not indicate any increases in the marijuana users. Studies looking at newborn birth weights and multiple biometric parameters after in utero marijuana exposure have found no increase in low birth weight and no association of marijuana use and preterm birth. Women reporting marijuana use should be counseled about potential adverse health consequences of use in pregnancy and emphasize that the purpose of screening is to allow treatment, not to punish or persecute. Seeking OBGYN care should not expose a woman to criminal or civil penalties for marijuana use. Insufficient data to evaluate the effects of marijuana use on infants during lactation and breastfeeding women should be informed that potential risks of exposure to marijuana metabolites are unknown. So again, the recurring theme over and over again, we really don't know a whole lot about this. It is best if you avoid it during the critical time of pregnancy. So here's Healthy Mom and Baby, which I happened to pick up in the office one morning. And sure enough, legal or not, it's bad for baby. And so this is what our patients are reading in the waiting room. Cannabis crosses both the placenta and the blood-brain barrier. Research in animals whose offspring are exposed to marijuana showed long-term negative emotional thinking and behavioral problems. THC may change certain receptors in the baby's brain, leading to problems with attention, memory, and problem solving. There's increasing evidence showing that both natural and synthetic THC are harmful to the developing embryo as early as 2 weeks after conception. During 1 to 4 weeks, THC may increase the incidence of anencephaly. Haven't found that in any of the literature I've seen, but it's in this article for our patients. Marijuana is linked to lower birth weight, decreased height, early birth, increased risk of preterm labor. Not in the literature I've looked at, in the article for our patients. Mothers have a more difficult and rapid labor with meconium staining. Not in the literature that I can find, in the article for our patients. Researchers have documented in the toddler and early childhood years learning and behavioral problems related to impaired mental development, hyperactivity, inattention, and impulsivity. Some stuff in the literature, not as clear or as dramatic as that. First trimester exposure and later are linked to problems with reading, spelling, overall educational scores at age 10. Not in the literature that I've seen, in the article that our patients are getting. There is something called a cannabis withdrawal syndrome that they mentioned. Upon quitting marijuana use, withdrawal may start within 10 hours and increase in intensity up through 48 hours. Restlessness, anxiety, irritability, insomnia, muscle tremors. Change in heart rate, blood pressure, diaphoresis, diarrhea, or others may occur. Breastfeeding in marijuana. I'm trying to remember whether this is in that article. I think it is in this article for our patients. THC can accumulate in breast milk in high enough concentrations that baby will pass THC in their urine during the first 2-3 weeks of life after birth. The effects of marijuana may be seen in the baby with quietness, sleepiness, poor muscle tone, ineffective nursing at the breast, and some experts advise against breastfeeding while on marijuana. And this is no longer in that article for our family. This is something else. Without FDA regulation or evaluation, there are no approved indications, contraindications, safety precautions, or recommendations regarding marijuana use in pregnancy and lactation. There are no standard formulations, dosages, or delivery systems, except that one slide with all the various different pills and their concentrations that I gave you. This is true. Smoking, the most common route of administration, cannot be condoned in pregnancy or during lactation because there's additional stuff in there besides the marijuana and the cannabidiol. So, ACOG also has some ethical issues involved with marijuana use, again from 2015. Routine screening for substance use disorder should be applied equally to all people regardless of age, sex, race, ethnicity, or socioeconomic status. Routine screening for substance use disorder can be accomplished by way of validated questionnaires or conversations with patients. If a group of patients come to your private office and you only drug screen or have the nurse screen because they happen to be a certain last name, or they happen to look a certain way, or they happen to have a certain amount of insurance, or they happen to be a certain race, you are liable for the feds to step in and say you're discriminatory. So if you're going to screen people, screen everybody, which is my favorite thing to do. Not to mention that you'd be unethical according to this policy. Routine laboratory testing of biological samples, however, is not required. So you can do your screen orally and only do biological specimens where you're at a specifically high risk. OBGYNs have an ethical responsibility to treat their patients with substance use disorder with dignity and respect, to try to establish a therapeutic alliance with these patients. OBGYNs should familiarize themselves with resources available through their local hospital, community, or state in order to appropriately and effectively refer patients for treatment. So as we were discussing in clinic yesterday, if you identify a group of patients that you think need specialized treatment in a specialized clinic, you should certainly refer them there. It'd be nice if you did more of an evaluation than the prenatal labs. But that's what you should do, is you should evaluate the patient and refer them to the appropriate location so they can get the best possible care. When a legal or medical obligation exists for OBGYNs to test patients for substance use disorder, there is an ethical responsibility to notify patients of this testing and make a reasonable effort to obtain informed consent. So again, when they come to high-risk clinic, they are informed. We will be doing drug testing on you once a month, and you just need to know about it. If you object to it, then you're welcome to go somewhere else, but this is how we do it. OBGYNs have an ethical responsibility to follow current best practices for controlled medications and to avoid patient misuse or diversion. So we're supposed to keep really close eye on how many drugs we give them. And of course, anytime you write a narcotic or a narcotic substitute, you should check it out in the state database. OBGYN should protect patient autonomy, confidentiality, and the integrity of the patient-physician relationship to the extent allowable by laws regarding disclosure of substance use disorder. Physicians should be aware that reporting mandates vary widely and be familiar with the legal requirements within their state or community, and should advocate evidence-based and consensual interventions related to substance abuse. OBGYNs have an ethical responsibility to their pregnant and parenting patients with substance use disorder to discourage the separation of parents from their children solely based on substance use disorder, either suspected or confirmed. It is unethical for an OBGYN to practice medicine with diminished capacity resulting from the use of alcohol or illicit, I've never seen illicit drug, but an illicit or illicit substance because it may put patients at risk of harm. If OBGYNs identify substance use disorder in themselves or colleagues, they have an ethical responsibility to safeguard patients by modifying their own practice and by seeking guidance from professional organizations to assist with resources for support and intervention. So what are these ethical rationales? Beneficence, the therapeutic intent, is the foundation of medical knowledge, training, and practice, and positive behavior changes arise from the trust implicit in the patient-physician relationship. And that's basically how, when we are in high-risk clinic, we begin the conversation with the patient. We understand that you have this substance abuse. We understand that it's a disease, much like hypertension, diabetes, lupus, or any other disease. We are not going to be judgmental. We are going to try and help you to work with this disease by reducing your dependence on this drug. Non-maleficence. There is an obligation to prevent or not to impose harms, including omissions relevant to the care of patients with substance abuse. Medical care may be compromised if a physician is unaware of a patient's substance use, so this may lead to misdiagnosis, unexpected or dangerous medication interactions, or psychosocial harms. And so we explain, well, that is why we're doing the various different urine testing that we're doing. Well, there's no way I could be exposed. Well, sweetheart, I'm sorry, but people come into your home and other people provide you with things, and somehow you could get exposed even when you don't think you are. Patients may also be harmed when substance use is viewed as a moral failing rather than a medical issue, and humiliation is a tool to force change unethically and professionally inappropriate, engenders resistance and acts as a barrier to successful treatment. Physicians need to model empathy and support rather than criticism when caring for patients with substance abuse disorder. Regarding justice, equitable access to care, fair distribution of resources, and non-discriminatory medical practices. Any screening for substance use must be equally and equitably applied. We already said that. Despite the significant involvement of male partners in perpetuating a pregnant woman's substance use disorder, no legal sanctions for abuse have been attempted. Also required is that preventive education and treatment referrals should be provided for all patients in whom substance abuse disorder is identified. Failure to diagnose and treat substance use disorder with the same evidence-based approach applied to other chronic illnesses reduces a patient's access to health care services and resources. Respect for autonomy directs that patients have the right to full information about their health and health care and the power to make their own health care decisions. Lately, we've seen a couple patients who've been hepatitis C positive and nobody's told them. And that would be a violation of this respect for autonomy. If you know they're hep C, you really need to tell them. Now, you need to tell them in private, not in front of the entire family, but they need to know that they've got hepatitis C. Respect and trust within the patient-physician relationship promotes patient autonomy and enables effective intervention for women with substance use by increasing motivation to change, supporting self-efficacy, and offering hope and resources. When a legal responsibility for drug testing exists, the physician should notify the patient and get the informed consent. When a patient declines to speak of drug, alcohol, or tobacco use, the physician should respect her decision. However, public health concerns may set limits on what the patient can refuse or choose. State laws create a significant ethical dilemma when they require physicians to report non-medical use of controlled substances by a pregnant woman or require toxicology testing for the mother and newborn. Our state law in Tennessee that requires reporting if you don't have a legitimate prescription will be gone in approximately 34 days, and so hopefully we won't have to worry about that law anymore. Such laws create an environment of patient denial and foregoing prenatal care entirely. Some of the cornerstones of ethical approach to substance abuse includes education, safe prescribing practices, advocacy for patients, protection of autonomy, confidentiality, and integrity of the patient-physician relationship, and it is inappropriate to avoid treating acute pain because of concerns for opiate addiction. Alternative and complementary pain relief modalities may be considered, and consultation with pain specialists often is appropriate for patients at risk for opioid withdrawal. I suspect I'm running out of time, so I will just point out that there are more things about marijuana available in the American Journal of OBGYN in 2015. They claim some of these things, such as possible increased risk of stillbirth, that I cannot find scientifically approved, but these are listed. For those of you who get an opportunity to go to a provider of marijuana, you'll see a thing like this and show you that the marijuana comes in spicy, sweet, sour, bitter, flowery, fruity, and here are the various different herbal. You can get a cinnamon flavored, rosemary, rose, raspberry, melon, diesel fuel flavored. Let's see what other things I had on here. A couple other cute pictures. This is a professional marijuana patch in Colorado. They're very careful. They wear gloves and masks because otherwise they might get high and burn the place down or something. These are the various different mood, the drugs types. This is good for eating and gastrointestinal. This is good for your mood. This is good for neurology. This is good for pain. These are the various different flavors. You get a soury kind of flavor over here. You get sweet over here, spicy over here. And then, of course, I want to tell you about Fiora. Fiora Company wants you to know that they are now selling vaginal suppositories of THC and CBD called Fiora Relief. Each suppository is 60 milligrams of THC and 10 milligrams of CBD, and they claim they can treat menstrual cramps and endometriosis, and that absorption for the vagina is very fast, faster than oral or smoking. Thank you. Any questions?